Okay, so I'm just pressing going live. But yeah, I'll be here anyway. I'll be reading out all the polls and everything. And
Okay,
I'll monitor the chat for you as well if anyone posts anything in the chat. So we have two people who've joined now. Okay. And I'll probably start around 1:30.
okay, perfect.
Just so we're good for timing.
Mhm.
Okay, I think we will make a start. Okay. Um, Hello everyone. Thank you for joining us today. My name is Gabby and I am the education lead for SUPTA. This week we're going to be focusing on large bowel and general surgery presentations. And we're really excited to have you all with us. Today I'm joined by Huda, who will be guiding you through our lower GI. And she is from Anglia Ruskin and is a final year medical student. To make this session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form. If you complete this, you'll receive a certificate of attendance and exclusive discount codes for Teach Me Surgery past the MRCS. And additionally, this session is being recorded. The recording and slides will be shared on our medal page in a couple of hours after the session, so please keep an eye out for that. We're also really excited to share that an exclusive question bank and other resources will be available on our learning portal, so please check them out on our website to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off Geeky Medics, anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we'll provide. The more sessions you attend, the higher your chances of winning, so be sure to stay until the end of today's session and attend as many of our other sessions as well. And finally, before we begin, I'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I'll hand it over to Huda.
Perfect. Thank you so much, Gabby. Welcome. My name is Huda and I'm a final year medical student. And today we'll be covering lower GI and some common presentations. So these are the learning objectives. We'll understand the anatomy, function, and common diseases of the large bowel, including diagnosis and treatment, and accurately identify and management symptoms of large bowel disorders and lower GI surgical conditions. We'll also gain knowledge of surgical procedures for lower GI issues, including indications, contraindications, and complications, and understand preoperative and postoperative care for large bowel surgeries. And also develop skills in interpreting diagnostic skills like endoscopy, colonoscopy, imaging, and lab tests for lower GI assessment. So to start off, we'll just go over some anatomy. I know the session yesterday, she went into detail about the anatomy, but just an overview. I don't know if you could see my, let me bring out yeah, there you go. So generally, you have the ascending colon, the transverse colon, and the descending colon, with the sigmoid colon going down to the rectum. Your arterial supply is supplied by the inferior mesenteric artery for the descending artery and the sigmoid colon. And then you also have the superior mesenteric artery, which supplies the other half. And in terms of the venous drainage, it comes from the splenic vein and the inferior mesenteric vein. Okay, so moving on, we're gonna go through some common presentations. So the first one is acute appendicitis. And it's basically the inflammation of the appendix, and it's the most common surgical presentation. So it presents with central abdominal pain, which radiates to the right iliac fossa, and you would get tenderness at the McBurney's point, which is this. So if you palpate in this area, they would get tenderness. So the area is between the navel and the anterior superior iliac spine, which is the McBurney's point, which you find the appendix. You would also have the Rovsnick sign positive, which is if you palpate on the opposite side, if you palpate the left iliac fossa, it causes pain in the right iliac fossa. You would get guarding as well and rebound tenderness. So some investigations you would want to do for acute appendicitis is urinalysis, pregnancy test if they're female, and if they're female, inflammatory markers, which would be high. You would also do an ultrasound and a CT as well. For management, you would do a laparoscopic appendicectomy and give prophylactic intravenous antibiotics. Also, guys, if you have any questions, just pop it in the chat. Okay, this is a question. I'll read it out to you all, and a poll will be sent out. So, a 31-year-old woman presents with a 4-month history of diarrhea, tenesmus, and occasional rectal bleeding. She reports passing stools 6 to 8 times a day, often mixed with blood and mucus. She also has experienced fatigue and unintentional weight loss. Physical examination reveals mild tenderness in the left lower quadrants, but no palpable masses. And the blood tests show hemoglobin of 108 and CRP of 35. The fecal calprotectin is elevated, and colonoscopy reveals continuous inflammation of the rectum extending to the sigmoid colon. So, what is the most likely diagnosis?
I'll just wait a couple of seconds for some responses. There's not many of you on the call, so please don't feel afraid to answer. Okay, so from the poll, we can see that 16% have voted for Crohn's and 83% have voted for ulcerative colitis, and there are 0 votes for irritable bowel syndrome and ischemic colitis.
Okay, perfect. Well done, everyone. The correct answer is B, ulcerative colitis. So the patient presents of symptoms of chronic diarrhea with blood and mucus, along with the colonoscopy findings of continuous inflammation and starting from the rectum and extending proximally, and also the characteristics of ulcerative colitis, which are all characteristics of ulcerative colitis. So it can't be Crohn's disease because it usually presents with patchy transmural inflammation, and you would also find skip lesions and can affect any part of the gastrointestinal tract. So with ulcerative colitis, you would see this continuous inflammation, which was shown on colonoscopy. So we'll go more into detail on ulcerative colitis, and then we'll compare the two between ulcerative colitis and Crohn's disease. So ulcerative colitis signs and symptoms, you would get bloody diarrhea and abdominal pain in the left lower quadrant, most likely, and you would also get tenesmus. So you have some changes in the bowel. You have macroscopic changes and microscopic changes. So that's how you can compare between Crohn's and ulcerative colitis. So in ulcerative colitis, you would get continuous inflammation, as we said, proximal from the rectum. You would get mucosal involvement only compared to Crohn's, which is transmural. Pseudopolyps and ulceration as well. Microscopic changes, you would get crypt abscesses and reduced goblet cells. And you would also get extra intestinal signs such as erythema nodosum and uveitis, and you would also get primary sclerosing cholangitis. So 80% of those with primary sclerosing cholangitis will have ulcerative colitis. So if you do see this, and they have symptoms of, they have bloody diarrhea, think of ulcerative colitis. So some investigations that you would like to do are routine blood tests to assess for any evidence of anemia, low albumin, or inflammation as well. So you would get a raised CRP and white cell count as well. And a fecal calprotectin and stool culture as well. So in the school microscopy, you would do culture as well, and sensitivity for C. difficile to exclude infective colitis. And the fecal calprotectin distinguishes between inflammatory bowel syndrome, which would be normal, and inflammatory bowel disease, which would be raised. So if it is raised, then you would think of IBD. Abdominal X-ray. So you would do an abdominal X-ray and also a erect chest X-ray in acute settings to exclude toxic megacolon and perforation. And long-standing ulcerative colitis will show a lead pipe colon on abdominal X-ray. So the management, and you would also do a colonoscopy. So you would do a barium enema as well, and a biopsy just to confirm the diagnosis. So now for management, you would, it depends on if you want to induce or maintain. So if it's a first presentation, you would want to induce depending on how severe their symptoms are. If it's mild to moderate, you would start rectal aminosalicylate and then move down to oral. And if that still doesn't work, then you give a oral corticosteroid. But if it's severe, you would give IV steroids. And to maintain their symptoms, you would give rectal aminosalicylate for mild to moderate, and then you would give oral if that doesn't work. In terms of severe, if it's severe, you would give oral azithromycin and oral metoclopramide. Does anyone have any questions? Does that all make sense so far?
I can't see any questions in the chat.
Perfect. So this is what you will see on chest X-ray, on abdominal X-ray, sorry. So you would see a complete loss of haustral markings in the distal part of the bowel, which is here. And this is known as lead pipe colon. And here on the second image, this is toxic megacolon. So this is something something very severe that you need to keep an eye out for. Okay, Crohn's disease. So Crohn's disease most commonly presents with a non-bloody diarrhea. You could also get mouth ulcers and perianal disease as well, perianal disease, and you would get abdominal mass palpable in the right iliac fossa. So again, macroscopic and microscopic changes. So macroscopic changes, you would see skipped lesions. So compared to ulcerative colitis, which is continuous. As I said, transmural involvement, and ulcerative colitis is just mucosal involvement. You could also get fissures and deep ulcers, also known as cobblestone appearance, and fistula formations. Microscopic, you could get granulomatose. Investigations, urinalysis, again, pregnancy tests if they are female, inflammatory markers, ultrasound, and CT. Management, to induce, you would give glucocorticoids and mesalazine. And to maintain, you would start off with azithromycin and then move on to metoclopramide and methotrexate. So this is just a summary between the two, which nicely summarizes everything. You can have a read through it later on. Okay, moving on to the next common presentation, which is diverticulitis. So diverticulitis is a subset of diverticular disease, which occurs when diverticula becomes inflamed or infected. So as you can see here on the picture, you have diverticula, which are these pouch or pockets in the bowel wall, and if it becomes inflamed, it is then called diverticulitis, which then causes these symptoms. So you would get altered bowel habits, rectal bleeding, and most commonly you would get pain in the left lower quadrant, and fever, and sometimes nausea and vomiting. So in aging bowel, it's normally naturally becomes weakened over time, which with the movement of stool within the lumen, it causes an increased luminal pressure, which leads to these outpouching of the mucosa through the weaker areas of the bowels, which leads to diverticula. So normally they're asymptomatic, and no treatment is required if you do see diverticula on endoscopy. The only time you would manage is if they do have the symptoms. and you would normally manage the symptoms with increased dietary fiber intake, analgesia, and only taking clear fluids, avoiding solid food until symptoms improve within normally 2 to 3 days. And if it is very severe, we would consider a segmental resection. So the surgical intervention is usually required in those with perforation, with peritonitis, and you would do a Hartmann's procedure. We'll go more into detail about the procedures. And if the symptoms don't settle within 72 hours, or if the patient usually presents with more severe symptoms, the patient should be admitted to hospital, and the patients are then made nil by mouth and given intravenous fluids and antibiotics inside of the surgery. So investigations, CT scan, blood tests demonstrating inflammation, and flexible sigmoidoscopy. And this is what you would see in sigmoidoscopy. So as you can see, the outpatchings here in the areas of more fibrable bowel lining. All right, so next, colorectal cancer. Colorectal cancer is the third most common type of cancer in the UK, and the second most common cause of death in cancer. So patients may present acutely with obstruction if the bowel, if the tumor blocks the passage through the bowel. So the patient's a surgical emergency with vomiting, abdominal pain, and absolute constipation. So you get change in bowel habits, depending. Normally, you could either loose stools or frequent stools. Unexplained weight loss, rectal bleeding, unexplained abdominal pain, iron deficiency anemia, and abdominal or rectal mass on examination. So investigations, normally you would do a fit test, and then a colonoscopy, sigmoidoscopy, and a staging CT scan. And you would also do a CEA. So the criteria for a 2-week wait, urgent cancer referral, depending on the patient's age and combination of symptoms. So if the patient is over 40 with abdominal pain and unexplained weight loss, over 50 years old with unexplained rectal bleeding, or over 60 years with change in bowel habit or iron deficiency anemia. So the fit tests are usually for the bowel cancer screening program, and they're normally for people aged between 60 and 74 years old, and which are sent at home to do a fit test. So if the results come back positive, then you would send for a colonoscopy. So the staging of colorectal cancer is Duke's criteria. So Duke's A would be confined to mucosa and part of the muscle of the bowel wall. Stage B is extending through the muscle of the bowel wall. Stage C is lymph node involvement, and D is distant metastasis. So management, surgical resection, chemotherapy, radiotherapy, and palliative care, depending on how severe the cancer is. So after the patient has a diagnosis, they're discussed with the MDT, which then they choose the choice of management depending on the factors, so such as clinical condition, general health, and the staging as well, and histology, and of course what the patient wishes. Okay, so another question for you all. A 48-year-old man presents with a 6-month history of intermittent left-sided abdominal pain, altered bowel habits, and weight loss. He has a 20-year history of diverticular disease. A recent colonoscopy revealed a large circumficial mass in the sigmoid colon, suspicious for a malignancy. A CT scan shows thickening of the sigmoid colon, no distant metastasis, and no signs of perforation or abscess. What is the most appropriate surgical resection for this patient?
Okay, I've released the poll, just let you know when the responses come through. Okay, so it would be nice if we get a couple more responses, guys. So 100% of people have voted for sigmoid colonectomy.
Perfect. So that is the correct answer. Well done to all. You know your stuff. So the appropriate resection for a mass confined in the sigmoid colon is a sigmoid colectomy. So the procedure involves removing the affected portion of the sigmoid colon and creating an anastomosis between the remaining colon and the rectum. So this is a standard management for a sigmoid cancer without complications such as perforation or abscess, of course. So these are the type of bowel resections. You have right hemicolectomy, left hemicolectomy, sigmoid colectomy, and a lower anterior resection, and abdominal perineal resection. So depending on where the cancer is, you would choose the type of resection. So Hartmann's procedure is sigmoid colectomy with the formation of end stoma. Okay, so stomas are artificial openings of bowel, which are artificially opened into the surface of the abdomen, allowing feces and urine to drain, bypassing the distal portions of the bowel or urinary tract. So some procedures may be temporary or permanent, depending on the underlying condition. So certain types such as loop ileostomy and loop ileostomies are often temporary and can be reversed once the underlying condition has been improved or healed. So the difference between colostomy and ileostomy is the location, how it looks, and what it drains. So colostomy normally is in the left iliac fossa compared to ileostomy, which is in the right iliac fossa. The colostomy is large bowel, and ileostomy is small bowel, normally the ileum. Colostomy drains solid stool and is flush to the skin, and the contents are less irritating. And compared to that, ileostomy is the liquid contents are more irritating to the surrounding skin, which is why it's a spout, so that the contents are not do not touch the surrounding skin. And the drain liquid normally stools directly into the stoma bag. So end versus loop, and what is the difference? So an end colostomy is created by bringing the end of the proximal colon onto the skin, allowing feces to exit into a stoma bag. The distal end of the bowel is sutured, and left in the abdomen, and the colostomy may be temporary or permanent, depending on the surgical goal. End colostomies are typically permanent after abdominal perineal resection due to the removal of the rectum and anus. And also, it could be temporary after emergency bowel resection. So like we said, procedures such as Hartmann's, where the distal bowel is allowed to heal. The rectum and bowel are then reanastomosed after later on when once the acute inflammation settled. So a loop colostomy and ileostomy is a temporary stoma designed to protect the distal bowel segment or anastomosis, allowing to heal. They may be called defunctioning loop ileostomy or ileostomy. So that's when you let the bowel heal. So it features two openings on the skin, one for the fecal drainage and the other for the distal inactive bowel. So the proximal end, which is also the productive side, is turned inside out to form a spout to protect the surrounding skin. And the distal end is flatter. So if you see on this side, there is two openings. So this allows you to distinguish between the proximal and distal portions of the bowel. So the distal end is flatter. Loop stomas are often reversed after 6 to 8 weeks once healing is sufficient. And loop ileostomies are frequently used after rectal cancer surgery to divert fecal flow and to protect the anastomosis. So, permanent versus temporary. The permanent ileostomies are created following a pan-procolectomy, where the entire colon and rectum are removed. And temporary may be used when it's unsafe to form an anastomosis during infection or inflammation. So indications for end colostomy is typically permanent after APR and or temporary for distal bowel rest in conditions like diverticulitis. And end ileostomy are permanent after pan-procolectomy with the total colectomy, removal of the large bowel, rectum, and anus. Loop ileostomy is defunctioning of the bowel, usually after rectal cancer surgery to protect anastomosis. And loop colostomy is usually used to bypass distal bowel disease, such as obstruction or perforation, allowing the proximal bowel to function. So this is a summary of what I just mentioned. You can have a quick read through that. Now we're going to move on to anorectal conditions. Quick question for y'all. A 52-year-old woman presents with recurrent bright red rectal bleeding, anal discomfort, and sensation of incomplete evacuation. She reports prolapse of a lump during defecation, and she has to manually reduce. She has tried over-the-counter creams with no relief. On examination, external hemorrhoidal lumps are noted, and anoscopy reveals a grade 3 internal hemorrhoids. What is the next best step management?
Okay, I've released the poll, so I'll let you know when we get a few responses in. I think people are thinking hard about this one. Okay, so 28% have voted for rubber band ligation, 0% have voted for conservative, 42% voted for hemorrhoidectomy, and 28% voted for sclerotherapy.
Okay, so the correct answer is actually A, rubber band ligation. So because the patient has grade 3 internal hemorrhoids, which prolapse and need manual reduction, rubber band ligation is the most appropriate for grades. So between grades 2 and 3, you would think of rubber band ligation. Because it effectively cuts off blood supply and causes the hemorrhoids to shrink and fall off. So it's a less invasive than a hemorrhoidectomy, making it the next best step in management. So sclerotherapy is an option for smaller internal hemorrhoids, so between grades 1 and 2, but it's less effective for prolapsing grade 3 hemorrhoids. So we'll talk a bit more about hemorrhoids. So hemorrhoids are abnormal swellings or enlargement of anal vascular Cushing's. So you would get painless, bright red PR bleeding unless it's thrombosed. You would also get anal pruritus and a palpable or protruding mass on examination. So these are the grades. So you would get grade 1. Investigations, you would do distal rectal examination and proctoscopy. So the difference between the grades are if they are external or internal. So external would be they would originate below the dentate line, and they're more prone to thrombosis and may be painful. Internal hemorrhoids originate above the dentate line and don't generally cause pain. So the absence of pain, unless the patient has thrombosed external hemorrhoid PR bleeding, is often associated with defecation on wiping. So grade 1 is no prolapse. Grade 2 is prolapse on straining with which spontaneously reduces itself. Grade 2 is grade 3 prolapse on straining and require manual reduction, as we had with our 52-year-old woman. And then grade 4 prolapse on straining and cannot be manually reduced. External hemorrhoids or lower grade hemorrhoids failing to respond to less invasive measures. So patients are normally required to maintain a diet rich in fiber and fluids to reduce the risk of constipation, limiting the exacerbation of hemorrhoids. So they could also start laxatives if needed, and consciously avoiding straining when opening their bowels. So for thrombosed hemorrhoids, which presents as painful purple protrusions, conservative measures such as ice packs, laxatives, and lidocaine gels are typically first line. But again, depending on the grade, you would choose your management. So for grade 1, you would do conservative management and give topical corticosteroids to alleviate pruritus and increase dietary fiber. Grade 2, you would maintain management may involve rubber band ligation, sclerotherapy, or infrared photocoagulation. So grade 3, rubber band ligation, which is this. It is basically a rubber band across the hemorrhoid, which cuts off the blood supply, and then it would fall off. And grade 4, surgical hemorrhoidectomy. So for thrombosed hemorrhoids, they're normally caused by strangulation at the base of the hemorrhoid, which causes a thrombosis, which is basically a clot in the hemorrhoid, and can be very painful. And PR examination would be very unlikely because it's impossible due to the pain. They would normally resolve with time, although this can take several weeks. So NICE suggests considering admission for the patients which present within 72 hours with extremely painful thrombosed hemorrhoids, and they may benefit from surgical management. Okay, moving on. Anal fissures. Anal fissures are a tear in the lining of the anus or anal canal. So some symptoms, you would get painful PR bleeding and constipation. And the majority of anal fissures occur on the posterior midline of the anal canal. So anal fissures often occur due to various causes. So most notably constipation. So the hard stools can cause tearing in the distal anal canal, especially when straining. And you could also get it when pregnant. So pregnancy increases the risk during the third trimester and post-delivery, and anal trauma as well. So some investigations you would consider if the fissures are found in alternative locations other than posterior midline, you would consider another diagnosis such as Crohn's disease, which also causes fissures. So further investigations is only warranted in atypical cases with potential signs of Crohn's. So the management is laxative and dietary fiber, and the use of topical analgesics such as lidocaine or lidocaine cream or jelly, and a GTN or Botox injection as well for the pain. And in severe cases, you would do a symphyctorectomy. Okay, so moving on to anorectal abscess. An anorectal abscess is a localized collection of pus in the perianal or rectal spaces, and commonly arising from an infection in the anal glands. So, signs and symptoms: you would get perianal pain worse on sitting, and some swellings as well, which are fluctuant and tender on examination. And you could also get pus-like discharge. You could also get systemic symptoms such as low-grade pyrexia and tachycardia. So investigations, you would do a DRE, and MRI pelvis is the gold standard for definitive diagnosis of anorectal abscesses. But if unavailable, then you could do a ultrasound. So the mainstay of treatment for anorectal abscess is early surgical intervention to prevent sepsis. So incision and drainage under general anesthetic is necessary when the degree of tissue damage is unknown, or in the case of deep perirectal abscesses within sphincter extension. So the wound can either be packed or left open, in which case it will heal in around 3 to 4 weeks. And antibiotics are used if there's an underlying condition such as diabetes or immunosuppression. If on presenting the patient is already septic, intravenous antibiotics will be needed. Okay, so now anal fistula. It is an abnormal connection between epithelialized surface of the anal canal and perianal skin. So it often arises due to an anorectal abscess or common complication of Crohn's disease. And you would get anal discharge and maybe purulent or bloody or both. And you would get anal discomfort or pain, often exacerbated by sitting or defecation. So management, you would do a DRE, and the openings of the fistula may be visible. And you could also do an MRI, and it will be characterized the fistula's course and delineate soft tissue structures effectively. So in terms of management, pain management and wound care is very important. So anti-TNF agents may be used if it's Crohn's related. Antibiotics in case of ongoing infection, and statin and fistulotomy. So a fistulotomy is suitable for superficial disease. So it involves laying the tract open by cutting through skin and subcutaneous tissue, as you can see here, allowing it to heal by secondary intention. And this here is statin, so a placement of a statin suitable for higher tract disease through the fistula attempts to keep the tract open. So thus draining any existing abscess as well as to prevent recurring formation of abscesses. So it's just important to state that the management will depend on the amount of sphincter muscle involvement, as cutting extensive sphincter will lead to incontinence. So that's just something to keep in mind. Okay, perfect. So now moving on to some general surgery presentations. We'll just talk about quickly about acute abdomen. So depending on where the symptoms are, you can find out what type of what will go through your mind, or the differential diagnosis could be. So right upper quadrant, the most common biliary colic, cholecystitis, cholangitis, and acute hepatitis. Left upper quadrant, you could get peptic ulcer disease, acute gastritis, and splenic infarction, rupture, or abscess. Left lower quadrant, normally diverticulitis or IBD. Right lower quadrant is acute appendicitis, colitis, or IBD again. And epigastrum, think of esophagitis, pancreatitis, or AAA. And diffuse locations, think of bowel obstruction or peritonitis as well. And there's a lot to note as well. Another question. A 68-year-old man presents with a 3-day history of abdominal pain, vomiting, and distension. He reports that his vomiting has become bilious and he has not passed any flatus or stool for 48 hours. He has a history of colorectal cancer, surgery three years ago, and on examination, his abdomen is distended with high-pitched bowel sounds. And abdominal X-ray shows dilated loops of bowel with air fluid levels, but no gas in the rectum. What is the most likely type of bowel obstruction?
Okay, so I've released the poll. Just waiting for some more responses to come in.
Mm-hmm.
Okay, so 83% have voted for small bowel obstruction and 16% voted for large bowel.
Okay, perfect. So correct. The answer is A, small bowel obstruction. So the patient's bilious vomiting and absence of gas in the rectum, and together with the X-ray findings of dilated loops of bowel with air fluid levels, are consistent with small bowel obstruction. So the high-pitched bowel sounds and lack of distal gas supports this. With previous colorectal surgery increases the likelihood of adhesions causing a small bowel obstruction. So it can't be a large bowel obstruction because it typically presents with the more distal symptoms, so like constipation and gradual distension with gas present in the rectum, unless there is a complete obstruction. So because there is no gas in the rectum, you would think of a small bowel obstruction. So bowel obstructions refers to when the passage of food, fluids, and gas through the intestines become blocked. So small bowel obstruction is most common than large bowel obstructions. And obstruction results in a buildup of gas and fecal matter proximal to the obstruction, so before the obstruction. And this causes back pressure, resulting in vomiting and dilation of the intestines proximal to the obstruction. And bowel obstruction is a surgical emergency, so you have to take this very seriously. So some causes of small bowel is adhesions and hernias for small bowel, which are most common. So adhesions following previous surgery are the most common cause for bowel obstruction, and then hernias. And for large bowel, you get volvulus and malignancy. In terms of large bowel obstruction, tumors are around 60% of cases. So signs and symptoms, you get bilious vomiting, abdominal distension, diffuse abdominal pain, absolute constipation, and lack of flatulence. And you would also get tinkling bowel sounds. So nausea and vomiting are normally late symptoms of large bowel obstruction, and which suggests a more proximal lesion. So some complications you need to keep in mind are hypovolemic shock, bowel ischemia, and bowel perforation and sepsis. So these are some things that you just need to keep in mind. In terms of investigations, abdominal X-ray is the first line, and you would see a distended small bowel loops with fluid levels. And you would think of small bowel obstruction if it is more than 3 centimeters in diameter. You would also do a erect chest X-ray, which can demonstrate air under the diaphragm when there is a intra-abdominal perforation. And CT is the definitive investigation and is more sensitive, particularly in early obstruction. Unis, you would see electrolyte imbalances, especially if they are vomiting profusely. You could also see a rise in serum amylase levels in small bowel obstruction. And venous blood gas, you would see a metabolic alkalosis, again, due to vomiting. And if they have bowel ischemia, lactate would be high. So in terms of management, it's normally described as drip and suck, which basically means nil by mouth and giving IV fluids to hydrate the patient and to correct electrolyte imbalances. And you would insert a NG tube with free drainage, just to allow the stomach contents to freely drain and to reduce the risk of vomiting and aspiration. And for surgical intervention, exploratory surgery in patients with an unclear underlying cause, and adenolysis to treat adhesions, hernia repair, and emergency resection for an obstructing tumor. So depending on what type, what the cause is, you would do the surgical intervention. So this is what it looks like on abdominal X-ray. So for small bowel obstruction, the features of small bowel obstruction include the central position of gas filled and distension of loops of bowel. The white lines passing across the full width of the bowel are volvulae convertants, and these are only found in the small bowel. So as you could see here, and you could also see the dilated bowel. In the large bowel, the colon is gas-filled and diluted down to the level of the sigmoid. The dilated colon is abruptly cut off at the level of obstruction, which is here at the X. This causes the obstruction in the patient was found to, for this particular case, it was a diverticular stricture. So the normal limits of diameter of bowel are for small bowel is 3 centimeters, for ascending colon is 8 centimeters, and cecum 10 to 12 centimeters, and rectosigmoid is 6.5 centimeters. So if you think it is a perforation, you would see intraperitoneal gas. And the haustra are like pouches formed by the muscles of the wall of the large bowel, and they form lines that do not extend the full width of the bowel. And these are seen in abdominal X-ray as lines that extend only part of the way across the bowel. So here we could see a sigmoid volvulus, which, as you could see, is looks like a coffee bean. So this is the coffee bean sign. So these are the edges of the sigmoid volvulus. So it is due to twist of at the base of the sigmoid mesentery, which is in a fixed position, which is here. This is the point of the twisting in the left iliac fossa. And this results in the appearance of the coffee bean sign. On this side, you could see a cecal volvulus, and when the cecum is grossly dilated, you could see the cecal embryo sign. So if you, with your imagination, look, this is the embryo sign. So this is the head. The head is here, like a little eye, and the tail here. So in cecal volvulus, the dilated cecum takes on a shape of, as I said, the cecal embryo sign. And this is the formation of large dilated cecal pole, which is the head, with one or two further segments, again, the body and tail. So another question, a 74-year-old woman presents with acute onset of bright red rectal bleeding and dizziness. She reports passing large volumes of fresh blood into the toilet bowl, but denies any abdominal pain or vomiting. Her past medical history includes diverticulosis and hypertension. On examination, she is hypotensive with a blood pressure of 90/55 and tachycardic at 110. DRE confirms fresh blood, and blood results reveal hemoglobin of 70 and a raised urea to creatinine ratio. What is the most likely cause of her bleeding?
So I have released the poll. All the responses are anonymous, so please don't be afraid to just guess an answer, guys. Okay, so 75% have voted for diverticular bleeding, 12% voted for upper GI bleed, 0 for hemorrhoids, and 12% for ischemic colitis.
Okay, perfect. The correct answer is indeed A, diverticular bleeding. So, because the patient presents with painless, bright red rectal bleeding in large volumes, combined with the history of diverticulosis, you would think of diverticular bleeding, especially because the patient is tachycardic and hemodynamically unstable with a blood pressure of 90/55. So it can't be upper gastrointestinal bleeding because you would typically present with melena or hematemesis. So because the blood was fresh blood, and in upper GI bleed, you would normally see a more darker blood. So yeah, you wouldn't normally see bright red bleeding in an upper GI bleed. And ischemic colitis normally presents with abdominal pain and diarrhea mixed with blood, which is absent here. Okay, so melena and rectal bleeding. So melena is a symptom requiring thorough evaluation to localize the source of bleeding, which is so melena is passage of black tarry stools, and rectal bleeding, hematochezia is passage of fresh blood per rectum. So description of stool and bleeding pattern can give you indications towards the localization of the bleed within the GI tract. So the possible causes range from issues in the high in the GI tract, resulting in melena, to colon-related problems causing blood mixed in with stool, and to issues at or above the level of the anus, which causes bright red blood. So the causes of high GI tract could be due to peptic ulcer disease, gastritis, esophageal varices, and malignancy. At the level of the colon, you would see mixed blood mixed in with the stool, which potentially caused by ulcerative colitis, tumors, and diverticulitis. And at or just above the anus, you would notice bright red blood, indicating conditions such as hemorrhoids or anal fissures. So, key aspects of clinical history is to find out where the PR bleeding is. So it is very important to have a good history from the patient. So you need to know the nature of the bleeding, the duration, frequency, and the color of the bleeding, and whether it's related to stool or defecation, and if it's mixed in with the stool. Any associated symptoms, including pain, especially associated with defecation, and any hematemesis or melena or PR mucus, previous episodes, and weight loss. Family history is very important to know whether there any family history of bowel cancer or inflammatory bowel disease. And you would also examine the abdomen and see if there's any localized tenderness or palpable mass. And on DRE, it is essential for any patient with melena or rectal bleeding. And especially if they are hemodynamically unstable, you should perform an A to E examination. So in terms of investigations, it will depend on the suspected origin of bleeding. So bedside, you would do stool samples, fit tests, fecal calprotectin, so it will be raised in inflammatory bowel disease. And you would also do bloods, so full blood count, see if there's any anemia, infection, or any inflammatory response. And coagulation can be beneficial to assess the impact of bleeding in the patient's overall health. In terms of imaging, you would do a upper GI endoscopy for suspected upper GI tract bleeding. and sigmoidoscopy if there's any suspected rectal or anal bleeding, and colonoscopy for suspected colonic bleeding. You would also maybe think of anoscopy, and CT AP angiography can be useful in some cases for more frail patients who can't tolerate endoscopy. So for management, treatment depends on the cause of bleeding again. So if it is, so you would treat the underlying cause, and if the HB is less than 70, they would require blood transfusion, and any patients on anticoagulation should be stopped. So if it is a peptic ulcer disease, think of PPIs and eradication of H. pylori if present. Gastritis, again, PPIs and H2 receptor blockers. For varices, think of esophageal varices and undergo band ligation. And for hemorrhoids and anal fissures, we just went through them: topical treatments and lifestyle changes and surgical interventions in some cases. So hematemesis, it is a clinical emergency, and it is characterized by vomiting of blood. And it is very important to take these patients very seriously, because it could be due to upper GI bleeding. So some causes for hematemesis include peptic ulcers, which are particularly duodenal ulcers, which may erode into blood vessels. Gastric or duodenal ulcers erode through the mucosal lining and may lead to bleeding in the stomach. So esophageal varices, often due to liver cirrhosis. You could also get gastrointestinal tumors, Mallory-West tears, coagulopathies. So think of any hemorrhagic disorders or anticoagulation use. NSAIDs, prolonged NSAIDs, again, may lead to gastric ulcers. So if patients present with hematemesis, may present with vomiting of bright red or coffee ground-like bleeding, and hemodynamically instability, melena as well, and abdominal pain. So investigations, you would do full blood count, coagulation profile, upper GI endoscopy, and a group and save and cross-match just in case for surgical intervention if needed. In terms of management, resuscitation, A2E and intravenous fluids and blood products, and correction of coagulopathies, especially if they're hemodynamically unstable, and endoscopic hematosis. So in terms for management, again, treat the underlying condition. Okay, last condition, dysphagia, which is normally due to, refers to difficulty swallowing, and it could be characterized into mechanical obstruction, such as esophageal cancer, or motility disorders like achalasia. So any patient presents with dysphagia should be assumed to have a upper GI malignancy until proven otherwise, and they should be put on the two-week wait under for upper GI endoscopy. So the two-week wait criteria is for esophageal/gastric cancer, and you would offer urgent OGD in people with dysphagia, or those with aged 55 years older with weight loss or any of the following, such as abdominal pain, reflux, or dyspepsia, barium swallow, and manometry, which is gold standard for achalasia. So management, treat the underlying cause. Conservative, you would think of SALT assessment, which is the swallowing therapy and speech and language therapists, and this may result in introduction of thickening food and drinks to aid with swallowing. And in terms of management, maybe think of PPIs for esophagitis, and calcium channel blockers for achalasia. Iron supplementations and management of underlying cause for underlying cause, and surgical intervention for obstructive causes for so dilation of in terms of achalasia and esophageal stricturing, and regular monitoring and palliative measures for malignant causes. So just quickly to go over some surgical scars. So if you notice them during abdominal examination, so the most common ones that you would see are open appendectomies, which is the Lance scar, surgical scar, which is this one here. You could also see a midline laparotomy, which is more less seen nowadays inside of the laparoscopic surgeries, where you could see 3 holes instead. Rutherford for kidney transplants, and transfers, as we said, for the stomas, and paramedian if there's any intra-abdominal abscess. So just have a quick read through these. These ones more for gynecological and obstetric conditions. So that's all from me. Thank you so much for listening today. Sorry if we went a bit over time, but thank you so much. If you have any questions, please do let me know.
Great. Thank you so much for all of that, Huda. You clearly know your content very, very well. Does anyone have any questions? If you do, please feel free to write them in the chat. And while we're waiting for some questions to come through, the feedback form is now available in the chat. So please don't forget to fill it out to receive your certificates and discount codes for Teach Me Surgery and pass the MRCS. Also, be sure to complete the Google form for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. And the link for that is also in the chat. Our next session will be next Monday at 6:30, and we'll be covering ear pain. So we'd love for you to join us again. Please make sure to follow us on our social media platforms. The links for this are also available in the chat, and you'll be able to receive updates on our upcoming sessions via these platforms. We'll also be posting our SBAs on our socials for additional practice. Don't forget to visit our website, where you'll find a resource bank with materials not just from this session but all our other sessions in this series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. And to access them, simply create a free account on our learning portal. We hope you found today's session valuable and engaging, and thank you again for joining us. We look forward to seeing you in our next session. Do we get access to the slides? I don't think you get access to the slides. However, there will be a recording, and there will be a summary of all of this on the website. Let's see if there's any issues with the form.
Also, to answer Zain, I can see comments regarding radiographic features of small bowel obstruction. I could just go back quickly for you. So do you want me to repeat the small bowel obstruction features, or is it...
I have released the feedback form, sorry. It's now available. You guys can submit.
Yeah, sorry. Just to quickly summarize, the small bowel obstruction, you would see vulvar confidence. So that's so for a small bowel obstruction, you would see features such as central position of a gas-filled and distended loops of bowel, and the white lines passing across the full width of the bowel. So as you can see, it goes it crosses the whole bowel, and these are found only in small bowel. And compared to large bowel obstruction, you would see the colon is gas filled and dilated down to the level of the sigmoid, which is here. So you can see the level of obstruction is here. And you would see, so compared to here, the lines crosses the whole bowel, compared to here, which is only half, if you could see here. Does that make sense? Do you have any questions? Okay, perfect. Does anyone have any other questions?
So just a reminder, guys, please fill out the feedback form and the Google form as well. We really appreciate all your feedback, and hopefully in the future you'll be needing some feedback as well soon. Okay, and are there any other final questions? Okay, well, if there aren't any other questions, thank you so much again for joining us. And please attend our other sessions as well. We've got two more on Monday and Tuesday next week at the same time, 6:30. So please do come to those, and hopefully you'll find them useful as well. Thank you so much, Huda, for today. You have done an amazing job, and explained everything in a lot of detail. So hopefully everyone is experts now. And if that's all, I think we'll end the session there.
Perfect. Thank you so much, everyone.
All
If you
right,
just fill up the
bye.
feedback form. Thank you.